diuretic even do? You can remember this by the memory trick, the 3 Ds of diuretics. First off is they are used to decrease blood pressure. Diuretics cause the body to lose fluids, which causes blood pressure to go down. They also cause diuresis. Diuretics increase urine output and remove excess fluid from the body. And lastly, they cause dehydration. Since the body is being flushed of fluid, it becomes dry inside, leading to dehydration. All right, there are 3 types of diuretics: loop, thiazide, and potassium sparing. First off is loop. The most common medication that falls under loop is furosemide, brand name Lasix. The most common medication that falls under thiazide is hydrochlorothiazide. This is easy to remember because it ends in thiazide. And then we have our potassium-sparing diuretics, which is spironolactone, brand name amlodipine. Now, the main thing exams will test you on is which one is potassium-wasting and which ones are potassium-sparing. So I have a little memory trick to help. Loop, think losing potassium. To help you remember, this is a potassium-wasting diuretic. You can also remember loop, think lost hearing. Because if you push furosemide too fast, it can cause ototoxicity, which is hearing loss or ringing in the ears. Now for thiazide, you could think tossing away potassium. To help you remember, this is also a potassium-wasting diuretic. And spironolactone, think sparing. To help you remember, this is a potassium-sparing diuretic. You can find more pharmacology memory tricks in the complete pharmacology flashcards.
All right, so I need to know. But some of it's a review, right? Thiazides, but they're coming back to life in our lecture today. Get the slideshow going here. All right, so it's diuretics today, much like hypertension that we talked about already this week. Super common, use them in a lot of things. But today we're going to get into, go ahead.
Sir, I don't think your mic is working.
Check. It helps if you turn it off. How about now?
Yeah.
All right.
Don't mind him, he's old enough.
Wait a minute, now I'm offended because I'm old enough too. I said I was going to wear my hearing aids this week. We'll see how we do it next week. All right. So diuretics, super common. We've been, talking about some coming attractions during our hypertension lecture. We mentioned how there was a question about the ACE inhibitors combination with the thiazides. And, we said, can that be used in heart failure? Because we had an asterisk of which ones were giving heart failure. And I said, yes, however, there's a stronger medication that we usually use in heart failure versus the hydrochlorothiazide, so you'll see it, but second line because the loops are stronger, and usually that's our first line. And we'll get into why, but we're going to get into all the diuretics. So I want you to keep in mind everything we learned. When we said the word diuretic, talking hypertension, we were talking what? Hydrochlorothiazide or thiazide-like. That's our first line. And why? Because the evidence is out there, it's evidence-based, that they decrease morbidity and mortality in hypertension. So when we're talking diuretics in hypertension, we're thinking one thing. Well, today we're going to talk diuretics as an entire class, which has some different subgroups. And, oh yeah, once again, depending on what your comorbidity is, and like the video hit on, do we need to spare potassium? Do we need to lose potassium? Do we need to spare calcium, lose calcium, and bring magnesium into the picture as well? And then, okay, what else do we need to do to the sodium that diuretics do? Do we need to waste it like the thiazides do, or do we need to retain it? So then we're going to get into all those one-offs for diuretics. And some of them are kind of very niche, but you'll need to know those niches, and we'll talk about those. We're going to talk about diuretics. Hypertension, we've killed it. Heart failure, we've touched it. Renal disease, we've hit it a bit. Every time we talk about chronic kidney disease, remember when we talked about that the thiazides below a certain creatine clearance isn't going to work. we have to get something else on board. Well, now we get to find out what we're gonna get on board. Electrolyte disorders, and there's also some emergency medications in this class. It's not just a water pill, right? You'll hear it all the time. It's a water pill, it's a water pill. But really, is diuresis about water? It's about the electrolytes and water following it, either in or out of the kidney or glomerular tubule, in or out of the blood. So it's really more about what water is chasing. Make sense? So it's not a water pill. It's, if you want to call it anything, it's a sodium or potassium or a calcium wasting or retaining pill, because water just follows sodium mostly. We're going to talk once again clinical uses. I'm going to try to give you some clinical pearls, and then we'll talk how it's tested. As you noticed this week, I try to throw in not only stuff that we're going to test you on as far as getting through this class, but stuff that you'll need to know when you get to the end of rotation exam, stuff you're going to need to see on the pants, because that's what the ultimate goal is. So I like to make sure that we're kind of all tracking these universal concepts that you're going to see forever as you embark on this new career as a PA. Mechanism based, and I've said it a few times during hypertension. If you think mechanism, you can't go wrong. If you kind of know what's happening in that nephron, we show that picture a lot, or I've shown that picture a lot, and kind of the red little dotted lines. It's happening here, it's happening in the collective duct, loop of Henle, wherever it's happening within that nephron, it kind of predicts what will happen. And we'll touch on the concept I introduced that if it's acting way over here on the left side, near closer to the glomerulus, counteractions further down the line are going to make it a weak action up here, right? It's going to make it a weaker diuretic because it's being countered by the systems in place further to the right, if you're looking at the picture of the nephron, which we're going to see ad nauseum today. All right. Yesterday, I told you I would hang the hypertension memory jogs. So they're hung on your card in Canvas. I think we got through 3 yesterday. I can't remember because Dr. Love, I didn't want to take up too much of her time. But I think there's a 4th question there. So the memory jogs, from if you bring up your card in Canvas and look at block 1 material, click on it, you go in, you'll see the lectures, and then now there's a new blurb that says memory jogs and check on learnings. So the check on learnings, as you saw yesterday, are going to have the question, choices, 5 choices, just like you'll get on your exam, like you've been seeing since last semester. And then when you go over to the answer, it's going to say why it's right, and then the 4 wrong or incorrect choices tell you why it's wrong. So you're really getting 5 questions out of every question. Does that make sense what I'm saying there? That if you know not only why things are right, but why others are wrong based on a mechanism, thought process, the Ross system, sodium, potassium pump, all those things, then you're going to have no trouble on the exam. So there's only 4 questions, yeah, but really in my mind, that's 20 questions. Because if you know why things are wrong, you know why things are right. We all tracking? So any big questions, I'm not going to sit here and read to you. It's just the high notes, thiazides, right? Potassium and sodium wasting. Get rid of it. That's why it's a diuretic. And it gives you some of those issues, i.e. with the uric acid and calcium. It increases your blood glucose, right? We have to be careful with that in our diabetic patients. Remember we said if the creatine clearance is less than 30, not working so much, got to think something else. So I won't go through all of these, but the high notes are just that. They're high notes, and the disclaimer is still there that no, this isn't after our 4 hours together on hypertension that you just look at these 2 to 3 slides and you're good. But they're going to be very close. You need to really know this and be familiar with everything we presented, unfortunately, right? So no surprises on any of those. Remember the contraindications. We're always gonna hit those because safety, right? Do no harm. Kind of the first rule in medicine. So You don't give things like calcium channel blockers to our heart failure patients. And we hit that. So, but all of these are posted as one file, just the memory jogs with the checks on learning. And we're going to get some more checks on learning today. So let's move right into it. We talked the clinical pearls for hypertension. All right, today, diuretics. You're going to identify where it works in the nephron. I will tell you right now that that's half the battle. Looking at our picturing and knowing where it's acting on the nephron and knowing what takes place at that point in the nephron is half your battle. So when you're taking that test, if you can picture, oh yeah, this acts there, this is where this happens, this is going to be the outcome, and this is going to be kind of, if things are working too well, what could happen, like we've talked about before. If we're giving them things that lower certain things, then sometimes we can get it too low. It's really that cause and effect relationship that we're talking about when we talk mechanism-driven processes. Really, at the end, what's the class? Where is it doing its thing in a nephron? Mechanisms of action, indications, adverse effects, contraindications, monitoring. We talked about that. We know what we have to monitor. Those electrolytes are what's going to give us, some systematic changes in our systems. A lot of times affecting our cardiovascular system, but other places as well, depending on the agent. The language is important. On the check on learnings, and I wanted to hit this point. The things I have bolded on the check on learnings, that's to cue you in to get you used to picking things out of question stems. Your test will not have bolded, potassium level, will not have bolded whatever the case may be. I'm just trying to get you accustomed to reading question stems and going, here's what they're getting at. This is what's important. Because obviously as you get further along in your career or your training rather, it's going to get a little bit more complicated. So all those little things in the question stem, sometimes there's things that are relevant, sometimes there's things that are not, as those stems get bigger and bigger as your knowledge base grows. So I'm just trying to get you should be pretty good with it at this point because you're sitting here in junior semester. However, when we talk specifically the antihypertensive, the diuretics, all the stuff we're doing in block 1, I'm showing you what are kind of important clues in a test question stem, or in clinic, when you see these things to pick them out and go, oh, problem, need to address that, okay? If you can answer at the end of this lecture, why this drug for this patient, you're good to go. Maybe not at the end of the lecture, but after you finish studying for the test at the end of the block. Major drug classes. Here's some new ones for us, right? Carbonic anhydrase inhibitors. They're listed there for you. Those are your major ones under that class. These are very niche. We got our osmotic diuretics, niche as well. Mannitol is your big player there. Loops, we mentioned that's going to be our big gun, first and foremost in heart failure. We'll tell you why. Those are the main players there. Thiazide and thiazide-like should not even have to bring up at this point, but obviously it's a diuretic. And then potassium sparing, right? Because the ones we've talked about so far do what to the calcium? The thiazides. Do they increase it or decrease it in your system?
Decrease.
Right. So you want to keep potassium in your system with a potassium sparing because you get hypokalemia when you have too much of the thiazides on board. So you got to know the electrolytes. Then we're going to talk about those drugs there under other drugs mentioned, and they interact with the diuretics clinically. That's why we're going to bring them up, mainly because it's pretty dangerous for those drugs to be affected by a diuretic, and we get toxicity, and we'll talk about why. But I can give you an exam hint. If you see a stem with a diuretic, digoxin, and potassium, think toxicity. If you see those three things together, think toxicity. And that's not our exam. That is for all eternal. If you see diuretics, DIG, and potassium, then you're gonna think there's gonna be some toxicity happening. And we'll talk about digoxin a little, very briefly. What do diuretics do? Yes, they make you pee more, right? They increase your urine output. Definition is a group of drugs that promote diuresis. What is diuresis? Increase urine volume, right? You're excreting more. Larger volume, more fluids. Now, these next two, really listen to the definitions of these two. It can be very confusing for not only students, but practitioners. Tubular reabsorption. Okay, first thought is, okay, we're reabsorbing things in the tubule, right? In the tubule of the kidney. Not correct. Not correct. What is tubular reabsorption? It's being reabsorbed in the blood from the tubule. Have that framework. Because if you get off thinking that things are going the other way, because the word to me sounds, are the two words, tubular reabsorption, tube is bringing stuff into it. Right? No, it's the reason it's reabsorbed, that would be tubular absorption, right? Absorbing something into the tube. Tubular reabsorption means your blood is reabsorbing something out of that tubule. And we're going to talk about certain places where that happens along the nephron. But that is a super, super, super high yield thing to understand. Get a frame of reference and keep it. Think about, or is your frame of reference what's going on in the blood? Or is your frame of reference what's going on in the kidney? And know that when you see those terms, what's happening. So if your frame of reference is the blood, then it's reabsorbing from the tubule in tubular reabsorption. The tubule is really not doing anything. The blood at that point in the nephron is able to reabsorb electrolytes, water, back into itself, right? Back into the blood. And then tubular secretion is what? The opposite. It's, once again, if my frame of reference for the words to make sense is the blood. Whatever works for you, the definition is that tubular secretion, blood to nephron. So if I think about blood, secretion makes sense. I'm secreting it into the tubule. And if I think about reabsorption, okay, I'm blood. I'm reabsorbing from the tubule. But what throws people off is that you say tubular, so it sounds like the tubule is doing something. It's more about where on the nephron things are happening in the tubule in relation to your entire blood system. We square on that? I know I'm kicking the horse, right? Because if you get off in that thinking and you start seeing tubular reabsorption, and then you're saying, okay, where's sodium? Oh, it's being reabsorbed here. It's in the tubule, so I'm going to, excrete more of it. No. Tubular reabsorption actually means that you're going to have more of whatever you're talking about in the blood, right? Because you're reabsorbing it into the body or to the blood from the kidneys in that system. Everybody square on that because it always gets people. Gets me too if I don't use that frame of reference. Because the words matter, but your frame of reference is more important because in the words you can reverse if you don't really know your frame of reference. Okay, ADH we're going to talk about. I think I hit it yesterday for a second, but regulates water reabsorption. Water reabsorption, where's it going? From the kidney, reabsorbed into the system, right? Into your whole body system, into the blood. So these definitions are not trivia, right? This isn't a trivia contest. You have to know these definitions to be able to think mechanically and physiologically where things and what things are happening. So that explains why sodium drives water, right? Not the other way around. Water pills aren't really doing much to water. They're doing things in the tubule with our diuretics that cause us to either reabsorb or excrete into the kidney, which leaves our blood either with higher or lower, whichever one we're looking at, on that exact, that mineral or that electrolyte or whatever we're discussing. All right, I think we all got it. Very common. Basically, underlying therapeutic principle of all of this lecture for all the diuretics with some caveats is what? Is that they inhibit sodium reabsorption. So if it's not being reabsorbed into the blood, where's it going? It's being excreted from your body by the kidneys. That's the main effect, right? So when you excrete sodium in water, you have a higher diuresis, larger volume of urine. And waste products that we all know from AMP1, that the kidney is going to filter those waste products. And oh, by the way, drugs included. All the medications that we're putting in are going out of our body somewhere. If not, we're going to have a buildup of whatever they are, whatever that drug is. So we excrete more sodium, water follows, plasma volume, blood volume is going to go down, blood pressure goes down. Hey, great, that was the goal. If we're giving a diuretic because we got too much blood, then we're getting edema, we're getting that pitted edema, that fluid collecting in our extremities, helps with that, good. So because we're getting rid of that excess fluid, all those things are, in concept, going down, which is why we use them. Water follows sodium. If you remember one thing from the next 2 hours, water follows sodium. So your diuretics are going to lower your blood pressure primarily by reducing sodium in your body, making sodium go away with the urine, versus being secreted back into the kidneys, right? All right. Physiology, everybody's favorite. So physiology refresher, we're not going to go super deep unless we have to on certain things. How we're going to determine how the kidneys are working, right? GFR, we've already talked about it, glomerular filtration rate. Kind of universally accepted that that's our best estimate, but it is an estimate. I mean, that's why you'll see it listed actually as eGFR, right? It's a calculation. You can't directly measure it. Normally, 125 to 130 milliliters per minute. You see some healthy young males versus females, some numbers there. Because age and sex does kind of alter it. So when you get your labs back and you have an eGFR on there, it's going to say, a normal, a male this age, a female this age, whatever the case may be. Then you have to say, oh, my patient is this age and this sex, and so this is what I expect it to be. They're close, but they're a little off. And then creatine clearance is what's usually used to estimate the glomerular filtration rate. It does slightly overestimate it, but it's what we have. So creatine clearance is used to estimate the GFR. But this matters, like we talked about, that some diuretics lose their efficacy when your kidney function decreases, your creatine clearance decreases. Which one have we already learned about? Which ones don't work as well once we get that GFR below 30? Or creatine clearance below 30. Thiazides and thiazide-like chlorothiazide. Thiazides will not work at a low GFR. But guess what? Lubes do. All right, what are the kidneys? Basically, they are designed to conserve sodium very aggressively. Keep the sodium in your body. 99% of filtered sodium is reabsorbed. Does that mean that it's reabsorbed into the kidney or reabsorbed into your blood? Into your blood, right? Reabsorption. Collecting ducts are under hormonal control. We already discussed that. Everybody remember what hormone, mainly? 2 hormones. Aldosterone and the other ADH. Anti-diuretic hormone. Think about the name, you know what it does, what the hormone does. Anti-diuresis. We define diuresis. So for anti that, then we go the other direction. Less diuresis. Fight the kidney's natural instinct to hold on to sodium. That's what the diuretics are going to do. To hold on to sodium in the body, i.e., have it reabsorbed in the blood. Everybody tracking what I'm saying? Not the kidneys aren't holding the sodium. They're keeping it in the body by having points along the nephron where it's reabsorbed into the blood. That's what they're designed to do. Our diuretics come in and say, no. Let's get rid of it so that water can follow it, i.e. sodium. Their counter regulatory systems usually are affected, i.e. the ROS. What's the counter regulatory system that happens in the ROS? Remember what cells are going to secrete renin? Based on decreased or increased pressure? Because it's a negative feedback, it's decreased, right? So when those go down, then you get an action. That's a negative feedback loop. And then renin comes out, and then we know that whole cascade. And what happens when we go from angiotensinogen to angiotensin 1, angiotensin 2, all the way down to the AT receptor. Everybody remember all that? Yep, we're getting there. All right. That's why diuretics often activate a counter-regulatory system like the RAS or ROS, whichever flavor you decide to describe it as or pronounce it as. I think it's important because I'm saying it again. Tubular reabsorption versus tubular secretion. Huge concept when we talk diuretics. Because all it's going to take is to have one, to anchor yourself to the wrong process of thinking. Then when you start to think mechanically, or when you start to think about that cascade, everything you're thinking is backwards if you're not anchored into your frame of reference for reabsorption versus secretion. And if you have to go back and relook at it, if you have to draw it on your scrap piece of paper, come 2 Mondays from now, and then whatever you got to do to anchor yourself into the concept of where sodium's going, where water's going based on, and where a lot of these things are going based on the tubule or based on the blood. However you decide to learn it. Tubular reabsorption, lumen, kidney lumen, hollow tube, lumen, remember that? Right. Where everything's kind of hanging out in the nephron, in the tubule. And 99% of sodium is reabsorbed till we get that diuretic on board, which is an osmotic gradient, which is why sodium is being followed by water and why water's following sodium. Proximal tubule, 99%. And that in the proximal tubule and then the collecting ducts. That's where like 99% of that is happening. ADH is going to be working there on the collecting ducts. That's where your anti-diuretic hormone hits. And we'll go back in a couple of minutes back to our picture that we've been using of the nephron left to right with our different actions that are taking place along it. I think in the next slide. Secretion, blood to lumen, secreting from the blood to the kidney, and then out of your body eventually. Certain drugs like the lutes and the thiazides will use the organic acid secretory system. I think we hit on it, but this is in the proximal tubules. That organic acid secretory system is saturatable. What's that mean? It can get full and not work right. And there's competition there. Anybody who was in your check on learning yesterday, what is competing there that if it doesn't get to be excreted from your system can build up and cause like toe pain and uric acid, right? So it's excreted through that organic acid secretory system. And so if it's not getting out, if it's being competitively inhibited, well, it's staying in It's staying in your system and it's gotta go somewhere. And uric acid likes to go to the joints, most commonly that first MTP joint, and it gets red and swollen and painful as hell, right? All right. So weak acids are excreted through that system. There's some examples. So those things are competing for excretion with the electrolytes as well. But that's how your body's metabolizing it. Like I don't know how much I've had of it yet, but when we talk about some of the NSAIDs or aspirin, yeah, it can cause some kidney issues, right? Weak bases also excreted there. Some we haven't talked about much. Just know it's a saturable system. We're moving those weak bases and those weak acids out. And so drugs are competing for that spot. Uric acid is a big one that you need to know. Here it all is. So all the drugs that we're going to talk about, where they're acting. You've had your A and P, so this is a refresher, and we've shown this slide a few times, but definitely worth revisiting. This is a great slide to go back and re-anchor yourself, right? Where are things happening? Which are weaker diuretics? Well, I've already told you, further on the left, there's compensatory actions happening on the right. So if it's happening over here on the left, and it can be compensated for, so if I'm making if I'm losing or excreting more sodium up here by an action of a diuretic down further in that nephron, further down to the right, then there's going to be a compensatory mechanism. That's why you'll see there that the loops and the thiazides are, such strong diuretics, is because they're further down the system, further along the process in the nephron. So the different diuretics working at different nephron locations, there they are, they're numbered. Excretion is secretion, right? But excretion is actually leaving the body, but it's secretion. Where's it going? Blood to the lumen, right? Remember reabsorption, lumen to blood. That's why it's so important that you keep that concept in mind. What's your frame of reference? Shows you where they work. Osmotics that are in the loop. CIAs, proximal tubule. That's the first one we're going to deep dive into. Thiazides, distal tubule. So hey, they're pretty strong because they're out in the distal tubule. Potassium sparing are in the collecting duct. So every adverse effect, lab abnormality, clinical use, all of that's going to make more sense based on where that medication acts in the anatomy of that nephron. All right, we know where they're at. We got this slide to reference, so let's talk about what they do as far as each of the classes. Segment by segment. PCT, right? Proximal convoluted tubule, 60 to 70% is reabsorbed here. Water is going to follow that reabsorption, right? It's also where the organic acid-based secretory system is. We discussed that. That's in the PCT. That's important because of those examples that we gave you, that a lot of diuretics are secreted into the tubule here, right? In the PCT. Non-filtered, some of them. They're going straight in. So the carbonic anhydrase inhibitors, that's the last time I'll say it. I'll now call it CIAs from here on out. They are working in that proximal convoluted tubule. It compensates downstream, so that makes them strong or weak diuretics. Weak, niche diuretics, certain clinical scenarios. If they're early in the nephron, overall diuretic effect is going to be compensated for down the line. Now we have the loop of Henle, two different segments, descending and ascending. The descending limb permeable to water, but not sodium. So what's that mean? Water is going to move out, and then you're going to that's what's concentrating your urine here, right? Because it is permeable to water. Water can get in and out, but the sodium's not able to be not permeable in this portion of the descending limb. Well, the loop of Henle in the descending limb of the loop of Henle. In the thick ascending limb, or the tall, you see it abbreviated TAL, impermeable to water. Well, exact opposite of the descending limb. The thick ascending limb is impermeable to water. It actively reabsorbs sodium, potassium, and chloride via the sodium, potassium, and to chloride transporter. Active reabsorption, reabsorbed into the kidney. Blood, reabsorption is into the blood. So that sentence alone that I just said makes it sound like that the loop of Henle in the thick ascending limb is doing something. So it kind of is based on its makeup, right? But really what's happening is because those electrolytes can or cannot in different portions of that limb move from the tubule into the blood. So that reabsorption that we're talking about in the thick ascending limb is reabsorbed into the blood. And think reabsorbed. So what's happened? I take a pill, any pill, doesn't have to be diuretics. I take anything in, let's talk a pill, a diuretic. And then it's in where? So my GI system, then it gets into my blood somehow, right? Different processes for that. We're not there yet, but so it gets into my blood. Well, then it's going to move and be filtered in the kidney at some point. Well, not every drug, but a lot of them are. So now it's in my tubule. So when I reabsorb it, I'm reabsorbing it back in the blood. That's another good way to think about it, right? I'm reabsorbing it where it started. Reabsorption. Reabsorbing back into my blood. Because it was absorbed and brought into the kidney. We'll give it back. I'm reabsorbing it. That work? All right. So the thick ascending limb, 25 to 30% of filtered sodium is reabsorbed here into the blood, reabsorption. So that's why loop is really strong. That's why they're powerful diuretics. Blocking sodium here is going to really inhibit the ability to concentrate urine. Distal convoluted tubule reabsorbs about 10% of sodium, impermeable to water. We're not going to get down into the nitty gritty of, oh, what's here, what's the percentage, and here, what's the percentage. But this is more for you to be aware so you can think about pathophysiology-wise or physiology-wise why things happen at certain points and why some have better efficacy than others, some being diuretics. And it's because of the makeup of the nephron and their ability to either absorb, reabsorb sodium, potassium, name an element, right? Or an electrolyte, rather. So distal convoluted tubule is where the thiazide diuretics work. Well, the red dots are way off to the right, so not a lot of places for it to be compensated for. That's why the thiazides are strong diuretics. Not as strong as loops, but when I say strong, they don't have as much of effect on the sodium transport. So unique to the distal convoluted tubule, though, is calcium handling. So now we're talking another electrolyte. But because sodium reabsorption is linked to calcium reabsorption, we hit on it yesterday, right? What could that help with? Kidney stones. Because you're taking my calcium and it's being reabsorbed back into my system versus staying in my kidneys where the stones are forming. So it can be useful for folks with kidney stones. Thiazides can help decrease the amount of kidney stones that they have because it's being reabsorbed back out into the blood at a higher rate. Decreasing your urinary calcium because it's not in my kidney anymore. That make sense? Everybody tracking how that works? But what can it cause? Now it's not in my kidney, so I'm not getting stones, but where's it at? It's in my blood and it's too high. It's called hypo or hyper? Hypercalcemia, right? And we talked about some of the side effects of that and why that. So if you think through the processes, you can predict the outcome. So calcium relationship there with the thiazides in the DCT, highly testable, as you picked up by now, because I've mentioned it 3 or 4 times in the lectures leading up to today and today, now twice. Thiazides, here's your quick down and dirty. Thiazides, decrease urine calcium, loops increase urine calcium. So when you're studying, if you're making little charts, what drugs is making my calcium up, down? Potassium up, down. Sodium up, down. It's a good way to do it. Because you have to know the difference. Because then test questions are easy. Is it hypercalcemia or hypo? Well, if it's hypo and it's this drug, I already know, then that's the problem. All right, so now the collecting duct, what it's going to do, just fine-tune sodium, potassium, and the water balance. So it's only a very small percentage is reabsorbed here. It's more under hormone control. So aldosterone is going to increase sodium reabsorption and potassium secretion here. So aldosterone's affecting that sodium and potassium. Sodium reabsorption, potassium secretion. Now we know why it's so important to know the definitions, to know where it's actually going. Because if you're thinking that the sodium is being reabsorbed into the tubule, exact opposite of the concept and what's happening physiologically in the collecting duct. Potassium-sparing diuretics are going to work here by blocking aldosterone. Why? Because we just said that the collecting duct is under control of the hormone aldosterone. So it blocks aldosterone receptors, potassium-sparing diuretics being hit, blocks the aldosterone receptors, or it can block the sodium channels there directly. So we already know this, right? Because we've talked about the ROS system. Anything that's going to mess with my aldosterone, whether the release or the blocking of my aldosterone, is going to do what to potassium? It's going up. Going up in your blood, right? Not in your urine. So anything that affects aldosterone, which is, oh, by the way, everything in the ROS system, right, is going to cause hyperkalemia. But we mentioned that. We just or reiterated it. If it's messing with aldosterone, which acts mainly at the collecting duct, it's going to cause hyperkalemia. If it's blocking the aldosterone, or lowering the amount that's made or activated or pushed out from the adrenal cortex. All right, here's our big idea again. All we did now, or done now to that picture, is added on what we said earlier. So this is for your visual learner, where things are happening with the electrolytes. We said it in words, but this is just in pictures. And then your T on the bottom left shows you which number is where. It's very useful to know at what point in the nephron these medications are acting. Because then you don't have to memorize stuff. You just know, hey, if it's here, and this is what happens here. If I'm blocking that in some way, or I'm an agonist to that, then I'm either getting less of it or more of it, depending on if you're blocking or you're being an agonist, or am an agonist. So you're either getting less of the effect you want or more of it. So the diuretics work by inhibiting sodium reabsorption at specific nephron locations, and the key to the whole lecture, water follows sodium. So if you follow the sodium, you know what's happening, because the water's coming with it. The location is going to determine how strong Closer to the glomerulus, weaker or stronger? If my diuretic acts closer to the glomerulus versus over here on the far right, down in the distal collecting tubule, am I going to be a weaker diuretic closer to the glomerulus or stronger? Weaker, because what happens as you move down that system? Compensatory mechanism. Okay. Now we're going to talk logically about all the medications because you know what's happening where in the location of the nephron. And this is probably a good spot to take a break before we get into pharmacology. So let's do like 10 minutes. So I have 1:47, so let's be back at 7 after. Oh, sorry. Y'all don't want to hear his question?
It's not, I just like using the same words. So I like different things for a lot of stuff, but for that point, kind of just waiting until he gets three other classes. Not crazy about that, but I'm like, I don't know where to find this thing. Because like that's, I like
sodium reabsorption back into the body.
Yes.
but yeah, every time I
Back in the
look
blood.
But the aldosterone promote potassium excretion.
and then if I look up alpha skydog, it doesn't give me the turn view so that you can get it.
More potassium is, yeah, potassium out, excreted.
That's
but-
normal. That's
Yes,
normal.
yes, sodium is reabsorbed.
Aldosterone antagonists, which means prevent that by giving it
Because now it's getting rid of sodium and was keeping the potassium.
do it the opposite.
Yes.
Because that's what you want, right? It's a diuretic. So you want to expel the sodium from water.
But you gotta understand what he just talked about.
Like reabsorption, secretion, they didn't matter so much earlier, but now it's a big deal.
But it's gonna be big ass error. But I might be able to have that. That will still show this, but it outlines this kind of. But I don't know if that's. It's not labeled. And it clearly shows this guy.
Yeah, it looks good.
I mean, it's sugar.
Oh, yes.
And I think white is
But outside, not inside. Right how we go out to library, outside of the building. No, not lunch. You've got minutes for lunch? Yeah. Alright. And then we can talk more when we walk.
We always see a lot of people walk up the top.
So it's just stronger away, like
labels most of the same stuff, and then point out the app. I haven't only clicked
Later on.
because I'm gonna flip the next one and actually what needs to come in really
So, that was really good about this. It's pretty good about just make an even better pass. Weaker stronger. I think we went in the thought process of saying, I think the bigger is because if you know that they don't really early, this is going to try and undo what you're doing here. And the boss
Yeah, I guess it's labeled otter. Otter.
That's where it makes you mind. It's not the drug destructive to get back. That makes sense. It is a stronger effect to attack.
Outside of like how things that I feel like pharmacology is
Oh my god.
I think
You've been showing that to everybody for the last 20 years.
yeah.
I need both of y'all to look at the doc and give the blessing.
No. Fuck it.
Well, I'll take your name off. I'm a racist.
Looks good to me.
The Johnson effect.
Looks good to me. He's got hella fingers right here. You better not take it.
You good? Okay.
How many fingers do they have?
It's supposed to be, I didn't draw the other arm. The way that the test, they had it written was like that. And I was just like, I just did this. I just made a bunch of circles next to each other.
Oh, I can see it on this one.
Yeah. The other one I just kind of.
Just a blast injury. He's gonna see this. Just be like,
What the? Oh, wait, where's the.
it shows a different on ours than yours.
Oh,
So we don't know
okay.
what we're looking at.
Well,
If he got my version, I'd be like, oh.
here, you have to do it after the. Oh, sorry.
You draw the show.
Now you can scroll. It's okay. Like, I already downloaded the PDF.
Wow, spell my name wrong.
Did I?
I'm a capital B.
Wait, how do you spell yours?
He got his friends right though.
I did. Yeah. The people that I talk to. Yeah.
I lost her. Wait, where's that? Where's that?
Two T's.
His is capital D or capital.
Show me the uniform.
Actually, no, I know.
I know. I know.
Prove it. So she'll be on the night. That's what Dr. Love said. I was supposed to have a twin. So is she going to have all the I'm not talking about fall asleep earlier.
I was.
You were like, Google Houston Romeo.
No, I tried. I could have Houston, no.
Huh?
Trash.
He said, all right, take 10 minutes. Be back 7 after.
That's like,
It was like the last week of our
How you
life.
going?
DC was coming down, and I was going to drive to see it. So 2.5 hours. What do you want her to do?
She's a show. She's a show. She sings on her show. I know she actually goes to her show.
She only goes to pub.
If she does selective content,
Wait, no, ladies don't. It's not her.
I swear to God. I listen to her every day.
If it weren't for the wind, that's her.
They're both the same person.
No, they're not.
She
Amy Wilson. No, it's not.
Oh, Ella
What is my birthday?
Ella Langley's
Oh, 4x4 by you. Oh, I did like I do. Really good.
I was like, I know they're the same person.
In a 4x4
I'm gonna check out the
Hang out.
no one's paying attention.
Watermelon moonshine.
Sounds like
Apple
watermelon.
tart.
Did she steal that from?
Drug.
He doesn't like pop.
Pop is terrible. All country music today, like, it's all because I can't focus on my heart. But like all the other countries, like me, like all my Canadian like that was
It's just she's young.
I think she's young. It's just that like it's because of what they consider country today. That's the worst thing. It's like they don't even consider hot rock like that's what they consider old school.
Instead, I listen to like one song like
Stuff like that.
I think we talked about it.
finish up diuretics today. And then we'll kind of same engagement yesterday, the check on earnings, and then you'll have that ready over the weekend. We're trying to get all of this block finished before you take the break. Hold on a second. You're back hot now? Okay. So we're trying to get through, we're gonna get through diuretics today. So you got this for the weekend, right? Then next week, you'll notice on the schedule before, we discussed it today, that we were gonna have 4 lectures, then you're gonna have your 4-day holiday, then we're gonna have 2 lectures, and then the test that next Monday. So I'm gonna try to get everything done, all the material presented to you before the 4-day. So we may go a little bit longer on that Thursday of next week, maybe 30, 40 minutes, because and I'm sure they're gonna let you know, we're moving some classes around. Maybe go through a little 30 extra minutes, and that way then you have the whole break and all the material. I know you got a poem test, right, tracking, but then we'll just probably get together and just take questions, and maybe we'll call it a review, maybe. You'll probably have a little extra time to study, i.e. that last day that is scheduled for Pharm. We may not, the goal is not to have to utilize that day and get it back to you. It's not free time, right? There's stuff that obviously you need to work on. So just kind of letting you know what my end goal is here. And so we're moving a little bit slower today on the diuretics, only because we're gonna have the weekend. Then I'll give you some deeper dives in angina and heart failure and heme next week. So hopefully this isn't as difficult as hypertension's been up to this point. Hopefully not. We all have our strengths and weaknesses though, right? All right. Well, diuretics, wide range of clinical settings. We've already talked about most of these. Obviously, edema is too much fluid you're holding on to. Give you a diuretic, you get rid of some fluid. Happens a lot of time, edema. Heart failure, heart's not pumping, fluid's got to go somewhere. Heart's not pumping around, it's going to go, right? Gravity's going to keep it down in your lower extremities, or around the heart, or backing up to the lungs, but we'll get into that more. And renal disease. So if your kidneys aren't getting rid of fluids, they're going somewhere. If I'm drinking fluids and I'm not excreting them, I'm not making urine, if I have no diuresis, then guess what? It's staying in me. So if we start to have pathognomonic effects from those fluids, then we will get a diuretic on board. Hypertension, we know it, we've talked about it. Kidney stones, we talked about it. Give a thiazide. Calcium, unique to the thiazides. Well, not unique to the thiazides, but unique for kidney stones, in that we can get the thiazides to put the calcium into the blood, take it out of the kidney to reduce the kidney stone burden. We're going to talk about glaucoma, altitude sickness. I got it. It doesn't really fit here. However, CIAs are diuretics. We're going to hit them in a second. So glaucoma and altitude sickness doesn't fit. It's your weirdo, drug that we're going to discuss, but those niche uses are important. Acute brain injury, once again, mannitol, kind of a niche, a very niche medication. It's considered a diuretic, so that's why we discuss it here. But just remember, in all these things, and hopefully you're starting to pick up on this, like we were talking about beta blockers and diuretics and things in hypertension and heart failure, that what's good for the goose may not be so good for the gander, right? What helps me in hypertension may not do anything in heart failure, or it might actually cause harm. So just keep in mind, if you understand the patient, you understand the mechanisms of what's going on pathophysiologically, you understand our normal operating system, the mechanics of the RAS system and whatnot, excretion, secretion, how it works when it's working right, and then when it's not working right, then it's easy to kind of pick up on, well, what can I do to make it work better?
For the CHF ones, I thought you said you would lose potassium with thiazides.
No, we're going to hit it specifically. Just remember with the thiazides, and we did discuss that you can use a thiazide in heart failure. However, loop is gonna be your first choice, and we're gonna talk about why. But yes, you're still gonna lose. Thiazides are gonna act the same whether you got heart failure or whether you have hypertension, you have both, whatever the condition, you're still gonna have the same effects from the hydrochlorothiazide. So goal is to match what you're trying to achieve to the mechanism that's going to achieve it. That's how you're going to choose your drug. All right, you're going to see it. You're going to see it forever. If you see DIG and lithium, so digoxin and lithium, we're going to start talking about toxicity. So what happens is with diuretic-induced hypokalemia, so your potassium goes low, and then you're going to get increased digoxin levels, which is an arithmetic, right? So now I'm bringing that digoxin level way up, so now I can go into some fatal arrhythmias. So it's a classic question of toxicity. Diuretics causing the hypokalemia, and that's going to increase your digoxin toxicity. Diuretics reduce sodium, right? We're talking about, when I say diuretics, we're talking about the class as a whole, right? Pretty much we said what all diuretics do. In some form or fashion, they're changing the absorption, reabsorption, or secretion of sodium so that water can follow. So diuretics reduce sodium, which causes the kidney to reabsorb lithium. So then you can get lithium toxicity. They're monitoring issues more than they are contraindications. It's just with lithium and digoxin, you're going to monitor those levels anyway if you have them on that medication. So you're looking, in the case of diuretics, you're looking at what's happening to my lithium levels that have been stable for X amount of time, or my digoxin levels, and now they're creeping up, they're creeping up, they're creeping up, and then you got to start looking at is there hypertension, antihypertensive drug causing this issue? Should we look at changing some of their medication, because you're losing potassium, right, with the diuretics, with the hydrochlorothiazide, but then if you want to spare it, then there's some medications we can use, right, because you're going to lose, as we discussed from the question too, you're going to be losing that potassium, so you can get hypokalemia with these diuretics. But there are potassium-sparing diuretics, which by just using the words, what's that mean? They cause diuresis, but you retain your potassium. Because, as I mentioned, the reduced, the hypokalemia that's diuretic-induced can increase DIG toxicity. And then is sodium with lithium reabsorption. So hypokalemia plus digoxin. Arrhythmias. Just remember it. So, and we already talked about the thiazides, but we're going to add the loops to that equation, can cause hyperglycemia. We talked about thiazides, which masks that hyperglycemia in our diabetic patients. So potassium is needed for glucose to enter cells. As we just said, the thiazides are going to decrease your potassium. So if you have to have potassium to get glucose into the cells, then I have a decrease in potassium. Well, where's my glucose going to do? It's not going to be absorbed correctly, so it's going to be floating around and you're going to have too much blood glucose. We all tracking. Thiazide and loop diuretics cause hyperglycemia, as we mentioned, because of that potassium deficiency. Diuretics also, as we've discussed, and you had to check on learning on it, hyperuricemia. Hyper, too much, uricemia, not urine, right? Uricemia, uric acid, gout. So we also talked about earlier the compensation at the organic acid transporter. These are all precautions, thus the heading. So when you have that competition, volume depletion will increase your uric acid reabsorption because of the competition at the organic acid transporter. So thiazides, gout flare. Right, that's the take-home point. Gout, high blood pressure, and thiazide, that's what's causing it, the thiazide. If we're asking in a patient with gout and high blood pressure and they're having gout flares, it's because the thiazide is on board and there's competitive competition. There's competition for that secretory system, and the gout is being retained. I'm sorry, the uric acid is being retained. Bless you. Okay, let's see, we're right here. Allergic, we talked about the similarities with the sulfamides. So if you have a sulfur allergy, CIAs, thiazides, loops, there's an exception, right? If you have a sulfur allergy, and it's on all the labeling, even though it's controversial about the diuretics and sulfur allergy, because it's really a sulfur, I mean, we won't really get that deep, but it's still labeled as caution sulfur allergy. But there's some controversy that you don't need to know. I'm not smart enough to fight that battle either. I just accept that there's a sulfur allergy. So then I'm going to use that ethacirinic acid loop, and we're going to hit it harder. Sulfur allergy, there's your exception. It's a loop diuretic. If you need a diuretic, they're allergic to sulfur, use the ethacirinic acid. Ethacirinic acid. Per-labeling, caution with the diuretics and the sulfur allergy. But whether that's completely true or not, I don't know. But I'm following the labeling because I don't want to lose my license or a bunch of money in suit. So. Sulfur allergy, need a loop, give them the ethacirinic acid. We're going to hit it. So this is what we've been talking about for all the drugs. Exam questions that we've mentioned quite a few times. They're written on how real-world prescribing works. You're tested how it works out there in the real world. So next, CIA, which we briefly hit, but we're going to go a little bit more into this niche diuretic. There's our friend from hypertension, that overarching concept that we use and refer back to for our antihypertensives. Well, we major one for diuretics too. I've already mentioned it. Where does it work? What electrolyte does it affect? It being a diuretic. Where does it happen in the nephron? What electrolyte does it affect? Who can get it? Who should not get it? If you can answer that, you're going to pass any question anybody can give you. Really. Where does it work? How does it work? What electrolytes and what patient should and shouldn't get it? Sounds easy, right? All right. So we're going to talk about CIAs first. Acetazolamide is the big one. That's an ophthalmic agent. And you just take it orally, but we use it for ophthalmic conditions. And rarely are the CIAs used as a diuretic. They have a diuretic-like effect, and we only use them for a couple of niche situations. Because the CIAs are more about pH than they are about volume. Everything else we've basically talked about has been salt goes somewhere, fluid follows it, right? Or water follows it. CIAs are more about what are they doing in the pH of our body, which everybody's favorite thing to talk about, right? Metabolic acidosis, respiratory alkalosis, all those fun things, right? You thought you'd never have to hear about again? Well, they're coming back to greet you today. We won't get that deep. I'm assuming you know it. So CIAs in the PCT, they inhibit carbonic anhydrase, which is why they're named carbonic anhydrase inhibitors. So don't get lost just remembering acronyms. If you know what the acronym stands for, CCBs, what do they do? Well, they block calcium channels because they're a calcium channel blocker. CIAs, what do? carbonic anhydrase inhibitors. They inhibit carbonic anhydrase. You'd be amazed that you get into this habit of just reading slides, right? All right, yeah, I got that. I got it. Then a test question asks you something as simple as what a CIA, or they won't put the full word out there, but what a CCB word acts. Because we're going to have acronyms, right, on the test. And then you don't know, or you don't know what a CIA does because you only memorize CIA. Memorize the whole word, speak with the abbreviations of the acronyms, but if you know the word and not just the acronym, you're winning half your battles. Because a lot of these drugs, their mechanism is explained in the name of the medication. So what does it do? Prevents conversion of carbonic acid into carbon dioxide and water. So that's going to decrease hydrogen ion secretion. Hydrogen ion secretion. What does that mean? Is hydrogen decrease going into the kidney or into the blood? Decreased hydrogen ion secretion. Decrease in hydrogen ion going into the kidney. You got it? Because we're not reabsorbing anything. So what you'll also get is an increased urinary sodium and bicarbonate excretion. So you're going to be peeing away urinary sodium and bicarbonate. The net effect is alkaline urine and hypochloremic metabolic acidosis. Urine's alkaline, blood is acidotic. If you can just remember those two things, you got CIAs. Right? Urine's alkaline, and you're going to have metabolic acidosis due to the hyperchloremic metabolic acidosis. It's in bold on your slide. So the urine pH is going to be up. CIAs, metabolic acidosis, not alkalosis. If you remember acidosis, metabolic acidosis, that's as deep as we're diving on that one. They have a moderate diuretic effect because of, we already talked about it, downstream nephron segment compensation for sodium loss. This medication, CIAs, this class, over just a few days, will develop a unique condition known as tachyphylaxis. What does that mean? Is that it stops working. It no longer functions as a diuretic. They're very short acting before compensatory mechanisms take over, and it's called decreased efficacy, parentheses, tachyphylaxis. Pretty quick, over a few days. You don't use CIAs for edema or hypertension. It's blocked early, compensations further downstream. Niche uses. Open angle glaucoma decreases aqueous humor production. So you're going to give a CIA for open angle glaucoma. It's a pill that affects the pressure in your eyes. Decreases the production of aqueous humor. We also use it more than likely you've heard of acute mountain sickness. And that, the process there, one second, let me make sure I don't lose my computer. Acetazolamide is going to be used for altitude sickness for metabolic acidosis. Altitude sickness prevention. You take it before it happens. Any of you that have read about these mountain climbers out on Everest and all these things, they take it before they go to summit, right? Before you get it. It doesn't work well after you already have mountain sickness or altitude sickness. They're absorbed orally well. They're not metabolized in the body. So basically, acetazolamide is the same going out as it was coming in. It's not metabolized at all. They depend on renal excretion. Kidney function matters, much like hydrochlorothiazides. It matters for dosing and toxicity. Common adverse effects: drowsiness, fatigue, headache. Hypokalemia. Almost all of our diuretics cause hypokalemia. hyperchloremic metabolic acidosis. Once again, that's the same as the medication we just talked about, right? Or same as the slide we just talked about. Adverse effect, kidney stones, because calcium salts are less soluble in urine. That's alkaline. If you have alkaline urine, which we said CIEs cause, and they cause metabolic acidosis, well, that alkaline urine, calcium is less soluble, so you're going to be more likely to form calcium stones. Alkaline urine increases calcium stones. Take home point there. Moving on. Contraindicated in liver cirrhosis because the metabolic acidosis can increase ammonia retention. So you can get hepatic encephalopathy. What's that mean? Problems with the liver and ammonia is causing your brain to not function correctly, right? It's affecting your brain, your central nervous system, because that acidosis can cause ammonia retention and precipitate hepatic changes and encephalopathy on your central nervous system. We're going to use CIE's caution in patients with COPD or respiratory acidosis. Acidosis, why? Because it causes metabolic acidosis. So we don't want to give them metabolic and respiratory acidosis together because they rely on a compensatory mechanism to maintain pH is the why or the so what, but you're not going to be tested on it. You will be tested on CIAs, not how the cirrhosis is going to cause hepatic encephalopathy with a CIA on board. So cyclosporine levels go up, which CIAs can increase them. You don't really need to know much about cyclosporine. You'll get it later, but really more we're talking about some heme oncology uses for cyclosporines. But it can cause an increase in those levels, which can be a problem for folks with any kind of tumor disease, which that causes kidney and neurotoxicity. Monitoring includes electrolytes, acid-base status. We just said it causes metabolic acidosis. That can be bad. So you're going to monitor it. More than likely, I can say in 20 years of practice, I've written exactly 0 prescriptions for CIA, ACIA. So, but I'm also not working at the base camp of Everest, so I don't know. Maybe those guys and gals are writing them all day long. But you're not going to encounter it that often because it is such a niche drug, but you still need to know about it. They alter systemic pH. That's the take-home point. Not just urine, but systemic pH. You're going to see patients on them for glaucoma. You're going to see it. I just have personally not been the prescribing provider for glaucoma patients. I've had patients with them on a CIA for their glaucoma. It's just that wasn't what I was treating them for. But would I still need to be aware of their pH status? Yeah, when it comes to writing other meds, I probably should be. I hope I was. I don't remember. Okay, they work in the proximal convoluted tubule, cause metabolic acidosis, weak diuretic because of all the compensation downstream. They're not first line for volume, high yield exams because they're unique. You will see that your pants and your pantries and your end rotations, anytime you can pull something out and go, hey, this is special, you get asked about it. Even though it's not super common as to what you'll do as a family practitioner PA. If you start working in eye stuff, you'll probably see it more. If you're doing wilderness medicine with a bunch of hikers that are, scaling peaks around the world, then maybe so. But exams do love niche, unique things because, well, they're easy to ask questions about. Sweet diuretic, glaucoma, altitude sickness, and it causes metabolic acidosis, so sometimes you will see it used to counter metabolic alkalosis. Probably an internist doing that on the ward, not you in an outpatient clinic or on a fob or on the ship or in an aircraft. You never know, so you have to know it. All right, moving on to the next class, osmotic diuretics. They behave differently from all the other diuretics we've talked about. There's really one thing to remember, mannitol. It's the prototype. It increases plasma volume, does not block a transporter. It does not rely on any kind of sodium channel. It creates an osmotic gradient. It works by osmosis. It's IV. So your big one here is intracranial pressure. You have intracranial pressure affecting your CNS system. It's an IV medication that can relieve that pressure on your brain by acting as a diuretic. So cerebral edema, intracranial pressure, start thinking mannitol. Now this one is way more common. Bless you. Mannitol, osmotically active, freely filtered at the glomerulus. It is not reabsorbed. Doesn't go back into the blood, right? Goes in, kidney brings it in, the glomerulus, out she goes. Stays in the lumen, so what's that going to do? Increase osmolarity and pull water into the nephron. Once again, water is following this osmotically active substance. So instead of sodium, with mannitol, the water is following the mannitol in. Stays in the lumen, pulls water in, and it also increases that, like we said, the plasma osmolarity, so it's going to pull water out of the tissues and into the vascular space. Then the water is excreted. So by osmosis, you put mannitol on board, water follows it in, out it goes. Now we can see how that will be a strong diuretic as far as reducing pressure on the brain and your CNS. It's mainly because it pulls it out of the tissue and into the vascular space. Works by osmosis. That's the short answer. Metabolically inert, CIA, we just talked about all kind of metabolic changes, causing us metabolic acidosis. Mannitol doesn't work on a transporter, doesn't affect hormones, it does nothing in the system except for make water follow it out so that water goes out of your system and you take the pressure off your brain and the cerebral hemorrhage or whatever condition is causing your cerebral swelling and intracranial pressure. It's IV, so we have talked about very few diuretics that are given IV. So if it says IV, you automatically start thinking a couple of the beta blockers or very few of the others that we've talked about. So, because usually we reserve that for emergency situations, right? So once again, I would say CNS pressure, intracranial hemorrhage, pretty much an emergency type situation. It can temporarily worsen heart failure. Basically, a transient volume expansion is going to explain all of those, or kind of lead you down the contraindication list. I think I've hit everything on this slide already. Acute care uses. This is an ICU or an ER. I'm not doing this on outpatient. Increased pressure, intracranial pressure, and an IV, it's mannitol. You can get the major adverse effects, like we talked about, a fluid shift, basically. So you can get pulmonary edema. Now that fluid's going into your lungs. Heart failure. Now you're getting fluid around the heart, backing up. So it can worsen if you already have CHF. Electrolyte disturbances, headache, nausea, vomiting. Patient selection, critical in this, right? It has to be an emergency situation where they need that pressure off their system quickly. If the kidneys cannot excrete extra volume, mannitol becomes very dangerous, right? If I'm making all of these fluids follow this osmotically active substance, mannitol, into my tubule, well, my kidneys better be functioning because now they have to get rid of all that fluid that just got shifted from the blood and the extracellular space into the kidney because the water followed mannitol in. So your kidneys have to work, which is the case with most of the diuretics we've talked about, right? All right. can't have an active internal cranial bleed and get mannitol. Pulmonary edema shouldn't be used because we talked about why, the contraindications, the adverse effects. That fluid shift is going to put fluid into your lungs, and that's going to make your congestive heart failure, pulmonary edema worse. Monitoring, no big surprises, right? Everybody know what the urinary INO is. We've talked about kind of the creatinine clearance and EGFR, filtration. What is filtration rate? What is INOs? It's simply in and outs, right? It's every single thing I put in by weight, milliliters usually, and then what comes out. So I'm literally walking around with a container collecting usually for 24 hours what comes out, and I'm monitoring what I put in, and then we're kind of going into the clinic and they're saying, oh, this is where it should be, and you're either making too much urine or too little urine, right? It's just another method of monitoring your INOs. But guess what? Where do we say this is happening? Probably in the ICU, so you're probably CAF'd or you have a collection receptacle right there. Probably not at home, having had your IV mannitol and peeing in a cup. So it's kind of easier to collect when you're inpatient. High monitoring drug. You're getting rounded on every few hours when you're on mannitol. Now we're moving into the loops. Most frequently used, most powerful diuretic in practice. Strongest in the world, loops. Your big players, furosemide. We had the slide earlier, the drugs we talked about. So furosemide, bumetanide, torsemide, and then we mentioned briefly the ethylserinic acid earlier. When you have a what? 2 slides ago. You can use this loop when you need a loop, diuretic, but you have that controversial labeling. Sulfur allergy. Remember? You got a sulfur problem, you need a strong diuretic on board. Ethylserinic acid is the one you're going to pull out. That's the loop. Loops are in the thick ascending limb of the loop of Henle. They're the best. They're the best at diuresis. The strongest. They don't have any of that tachyphylaxis phenomenon that we saw earlier, to where they stop working in a very short time. They're very, very good at what they do, i.e. diuresis. If you're going to have an acute volume overload, you're going to get a loop. What's an acute volume overload? Your system's got too much fluid in it. We already mentioned that it's the mainstay in what condition that thiazides are used in, but it's not our go-to first-line backbone. I think we asked a couple of questions about it so far. Yeah, heart failure. It's anything that's a lot of fluid and you want to get rid of it quickly, and you need to get rid of it quickly, it's a loop. They block the sodium, potassium, and 2-chloride co-transporter in the thick ascending loop. So we've talked about, if you understand what's happening at different parts of the nephron, now we're going to block that. Well, whatever was happening there before, it ain't happening now, right? So if potassium was being reabsorbed there, and then we're blocking it, is it going to be reabsorbed there anymore? No. And then the opposite is true, right? If potassium was being secreted back into the tubule there, and then we block it, well, now it's staying in the blood, which is, the latter is what's happening, because it's going to be, the former is what's happening, because it's not a potassium-sparing diuretic. That's a class all by itself, so if you remember that, and you kind of know that what's happening with potassium at that portion of the, at the nephron, and oh, by the way, it's a loop diuretic, so we know it's in the loop. So you got it made if you remember that. And, well, hey, it's not potassium sparing because it's not that class, and it's a loop diuretic, so it's probably happening in the loop, and that's where it's blocking that sodium potassium 2-chloride transporter, which means it's affecting the reabsorption of it so that we can excrete it. Not reabsorbing it, blocking the reabsorption so that it can stay in our lumen and go out with our waste. So Massive sodium and water loss. Big problem with this drug is it does its job really, really well, right? You're gonna start seeing, it's not hard to get a patient hypotensive quickly on a loop diuretic or strong loop diuretic. They're gonna lose massive amounts of potassium, calcium, and magnesium sometimes. Obviously, we do the same thing we did in all of our discussions, start low, go slow. And what else? Anytime we're talking about a diuretic, what's one of the main things, once we start it, what are we looking at? Monitoring. What are those electrolytes doing a few weeks after we get them on board, right? Because blood pressure, now some of these medications we're talking about work very quickly, a little bit different from hypertension, because when we're treating intracranial hemorrhage, we're not bringing people back in a month to check it, right? But just remember, if there's a danger from doing too much, you want to start low, go slow, and then check it, see where we're at. There is a high ceiling diuretic. So the more you give, the better it does. That's how you can get into flirting with dangerous territory with loops. You keep going up with a loop, well, that blood pressure is still going down. And so is the sodium, and so is the potassium, right? And so is the chloride. So is the chloride. Massive sodium and water loss, loss of potassium, calcium, magnesium, and we all know that when we get too lower levels of those electrolytes, bad things happen to our whole system and a lot of times our heart with arrhythmias. You can't concentrate urine anymore if you have too much diuresis, so now you just shut your kidney down. High ceiling diuretic, the more you give, the more it's going to take. The higher you go, the more electrolytes and fluid, i.e. water, is coming out in the urine. Loops, hypo anything, right? If you see hypokalemia, hypocalcemia, loops have to be, now there's some other medications we've talked about, but definitely you need to think about a loop, because does a diuretic, class thiazide or non-thiazide, does that cause hypocalcemia? Or does that cause hypercalcemia? We give it for kidney stones, right? Hypercalcemia. Because it's pulling out of the nephron, because we don't want calcium building up into our kidney. All right. Loops will work even in pretty poor renal function. They act quickly. That's why we give them an acute pulmonary edema. When you think about this drug class, just whatever you need to get fluid off quick, unless there's a contraindication, which we're going to get into, you're going to throw a loop on board. Pulmonary edema is a big one. They even work in poor renal function. So what did we say about thiazides? Creatine clearance below what? Did they stop working? Below 30. But guess what? If you still need diuresis, your creatine clearance is below 30, throw a loop in. They still work at even a low kidney function level. So even below 30 for the creatinine clearance, they're still going to do their thing. They're life-saving and they're dangerous, right? Best of both worlds. What it does well, but it can do too much of a good thing. All right, and we're talking about there the clinical uses. If you got too much potassium, you can get rid of it with a loop. If you have too much calcium, you're going to stimulate tubular calcium excretion. Excretion meaning I'm taking it out of the hypercalcemia, out of the emia, out of the blood, into the kidney to get rid of it. All right? So that's the tubular excretion. All right. Electrolyte disturbance, most common. I gave you that in the take home, right? Just a moment ago. Low potassium, low calcium, think loop. And magnesium is not great to have low either. So loops affect magnesium levels as well. So if you get hypokalemia, hypocalcemia, or hypomagnesia from a loop, that's a strong contraindication on adverse effect. You're just going to monitor it, right? And make sure we don't get too low to where we start having electrolyte disturbances. Hypomagnesemia, you're going to see more on long-term loops. You're going to be on it for a while. It's not going to be like your calcium and your potassium to where it's going to be a quick turnaround. Cardiac arrhythmia is when those things start happening. Muscle cramps, weakness, potentiation of DIG toxicity. We talked about that on an earlier slide. Electrolyte loss is think of the loop. Think in loops. Kind of a unique one is the autotoxicity, which is mentioned there. So it's reversible, but it could potentially cause permanent tinnitus and hearing and deafness, hearing loss, in very high doses, peak concentration. What do we say about loops? Do they have a low ceiling effect to where we get to a certain level and they stop working? No. So you can actually keep pumping loops on board and raising that dose, and you can actually permanently deafen someone. We talked about the ithosyrenic acid, and furosemide, bumetanide, and torsemide, below the ototoxicity. That's just showing you which ones are more causative of that specific adverse effect. So although you may want to use the ithosyrenic acid during the sulfur allergy, you don't want to get too high because now we're going to have some ototoxicity, some tinnitus, and possible permanent deafness. And we talked about the other things it can cause. If you are amuric, you don't need to be given a loop because you already can't concentrate urine and there's no diuresis happening. And now you're going to be asking those kidneys to do a lot of that. And if they're not functioning, we talked about the creatine clearance level that can work very low, but if anuresis, it ain't happening at all, well, that's, you just found their limit. You have to have some kidney function to be able to utilize the drug. Severe electrolyte disturbances, if they already have it, then you probably don't want to get a drug that's going to drop that potassium and magnesium and calcium on that patient. We talked sulfur allergy, ETA being true sulfur allergy, loop diuretic we want to grab for. I mentioned it. Sulfur allergy, you need loop diuretic, use that ithosyrenic acid. Aminoglycides are a drug interaction, kidney toxicity, ototoxicity with the loops. NSAIDs, we already talked about that they reduce the diuretic effectiveness. We talked why. Remember the picture with the four depictions of the afferent, afferent, efferent arteriole, and what happens with NSAIDs and the prostaglandins, and then what's happening with the diuretics, that they compound to decrease your GFR. Same theory. So sometimes I started my patient on an NSAID, or I think I mentioned your patient doesn't know that HEB brand ibuprofen that they just bought can have adverse effect on their kidneys, especially now when you're bringing on drugs and medications that affect it as well. So NSAIDs reduce the effectiveness because of that prostaglandin, renal prostaglandins that we discussed. Same with the hydrochlorothiazides. They dilate the afferent arteriole. You can have reduced sodium reabsorption in the loop. The loops also counteract ADH-mediated water resorption. We said that happened way down here where the ADH is affecting anti-diuretic hormone release from the brain, so it can counteract that, that anti-diuretic mediated water reabsorption, anti-diuresis. So your brain's kicking it out saying quit peeing, we need to save fluid. The loops are so strong that they're going to say no, keep peeing, we don't care what the brain says. Don't worry about that ADH. You can counteract it. Okay. This is the why, basically, right? The why of the NSAID interaction. And the nephrotoxic agents. Monitor them. Kidney function, serum creatinine, BUN, electrolytes, blood pressure, daily weights. Daily weights, kind of hard to get outpatient folks to do daily weights, but if you can, good job. If they're inpatient, you're gonna get it, right? Volume status, just you're looking for that hypotensive state. Or symptoms of the electrolyte imbalance, right? We talk weakness, confusion, fatigue, palpitations, heart abnormalities, heart arrhythmias specifically is the abnormality. Daily weights often more informative than urine output. It can be miscalculated, but daily weights, usually that's your inpatient folks. All right, there's a good summary of the loops. In the interest of time, I'm going to move on to the next class. As you have that here, and I've discussed all of it. So just acquaint yourself with the table, but it's just a summary of everything we talked about. And guess what? We are spending 0 time on thiazides. We all good? Because we're not talking heart failure right here. We're just talking thiazides as a diuretic. Everything on these next 4 or 5 slides we have hit in the last 4 hours. So they're in there for a refresher. It's the same slides, actually. So obviously you need to know it, but the test isn't going to say, oh, this is from your hypertension lecture, this is from your diuretic lecture. It's the same material you need to know, so I don't need to go over something that we discussed and I gave you questions and answers on. And oh, by the way, there's also the memory jog slide that includes the thiazides at the beginning of this lecture. Is everybody good with that, or need to hear it? I don't think anybody in this room needs to hear me say thiazide and thiazide-like anymore, right? We've hit it. Look back over it. Obviously, you need to know it. It's a huge class that you need to know, but because I'm giving it today versus day 1 does not make it any different information. First line hypertension, that's the big one. Hypercalciuria and nephrolithiasis. We discussed it. Like I said, we're going to move on because you've had about 3 hours of thiazides at this point. There's a summary chart. That may be the only new slide on thiazides that you did not see on Wednesday? Yeah, Wednesday. So potassium sparing, we're going to hit that for a few minutes, and then we're going to be done for the day. They're a weak diuretic. Primary role is electrolyte management. We talked about why they're weak because of where they act in the nephron. If potassium is the problem, not volume, then you're going to start thinking about those potassium-sparing diuretics. 2 distinct subclasses, they're broken out right there for you. The aldosterone antagonists and the sodium channel blockers. The name of the medication and the class tells you what they do, right? One's going to antagonize aldosterone, the other one's going to block that sodium channel. And then the drug is listed there. Both act in the collecting duct, but different mechanisms. Same location in the nephron, different targets. The aldosterone antagonists are going to block the receptors in the collecting duct, the mineral corticoid receptors in the collecting duct. So you're not going to get what aldosterone does, right? Which we've already talked about. Aldosterone causes you to reabsorb that sodium. Well, if I'm blocking that effect, guess what? I'm not reabsorbing that sodium. Which is where? Reabsorption. Is it going to the kidney from the blood or from the kidney to the blood? From the nephron tubule to the blood. Reabsorption. There you go. You're reabsorbing it, tubule to blood. Okay. So beyond the diuresis, we remember everything that aldosterone does. And so a lot of the same actions that we saw with the RAS inhibitors, as a matter of fact, the same exact actions. Because whether it's being blocked high up in the RAS cascade or it's actually being blocked early in that cascade is going to determine if we're still activating or not activating our aldosterone to be produced. But if we're reversing what it does, it's the same as all the other classes we've talked about to block the actions of aldosterone. So The aldosterone antagonists do have some mortality benefit in heart failure with reduced ejection fraction. We discussed that briefly, but it is a heart mortality benefit or overall mortality benefit with that heart failure with reduced ejection fraction from aldosterone. And then the sodium channel blockers work by a different method altogether, and obviously by the name, sodium channel blockers block the sodium channel, so it's working differently than the aldosterone antagonists. Specifically, beyond the diuretics, what the aldosterone blocking does, it prevents remodeling of the heart that aldosterone can cause, right? So you can get fibrosis of the heart and remodeling of the heart from too much aldosterone. Well, if we're blocking aldosterone, whichever medication we're using in the RAS that affects the RAS system, ultimately aldosterone, well, we're giving some cardiac benefits, right? We're decreasing that aldosterone-induced fibrosis or remodeling. So that's why it's good for folks in heart failure or with reduced ejection fraction to have an aldosterone blocker on board, which is the mineral corticoid receptor antagonists, or MRAs, potassium sparing diuretics. All right, we're going to hit this slide and we're going to call it for the day. You'll still have the slides, but I'll probably re-hit this a little bit on Monday. These last few slides, you'll still have them to review, and the pearls are there. As far as remember the memory jog, we're going to do them at the end of each lecture. Your questions are already there as well. I will post them on your card tonight, just like I did with hypertension yesterday. So you'll have, I think it's 4 questions, but 5 answers with the justifications of yes, no. So really, you're getting 20 questions if you understand the correct answers, why it's correct, and the incorrect answers and why that's incorrect. So it's really kind of like get 20 questions out of 4. So we are going to actually cut off now. You can review these slides, but I'll finish up and we'll do the memory jog on Monday. You got plenty to study over the weekend, so don't sweat these last few because we do have an extra lecture built in after the break if we need to hit it. But we're potassium sparing, that's a good spot. There are some keys I want to hit there, but you do have the memory jog for the potassium sparing and a couple other little classes there mentioned at the end of this lecture that I'll hang in 5 minutes, and the check on learning questions will be hung right below where the hypertension ones are now. So I'll stay around in the back of the room so we don't interrupt Dr. Love's class if you have any questions. If not, bring it Monday. We'll hit this quickly, and then we'll move on to angina